Hi, I'm Dr. Naveen Vanga with the University of Texas at Houston, and here in the operating room, we've got a number of quality initiative improvements that are underway. One of the more successful projects has been the surgical safety checklist. Let's take a closer look at that. The project originated as a collaboration between our surgeons and anesthesiologists in the Division of Pediatrics. The goal was to create a meaningful and consistent checklist that addressed all surgical safety issues. The surgical safety checklist consists of three main events. The first event is the briefing, which occurs prior to induction and involves the circulating nurse and the anesthesia provider for the case. The second event is the surgical timeout, which occurs after the patient has been prepped and draped prior to skin incision and involves all team members. And the third and last event is the debriefing, which occurs after the case is complete prior to the surgeon leaving.
Okay, good. Mom and Dad, we're gonna do our checklist, and I will ask you the full name of your daughter, please.
Okay.
Rowan Rao,
Her date of birth.
6/27/2010.
Okay, she is not allergic to any medication.
Correct.
Her band is correct, right? Have our anesthesia checklist in the ORs ready, right? And we have no risk of difficult intubation. We have no risk of aspiration. She will be intubated. She will be extubated at the end. We'll give antibiotics and stuff according to our protocol. And she will be in supine position for the procedure. The goal was to improve safety of our pediatric patients. And so the problem for us was who needs to do it. We also wanted it to do always at the same place. So not sometimes in the OR, sometimes in a pediatric holding area. So we decided we'll do it in a pediatric holding area, and the attending anesthesiologist and the circulating nurse from the OR should do it.
Okay, can we start with timeout, and we'll start with introductions at the top with the anesthesia, please?
Yeah. Matusak, pediatric anesthesiologist. Christine Anthony, the resident.
Young Fan, urologist.
Admin assistant.
Edie Haskell.
Chris Stryker.
Hannah, circulator.
First thing we do is introduce everybody. So everybody in the room knows who is the other person standing there and doing something with this patient. And in a busy operating room where sometimes you work for the very first time with the surgeon, you sometimes barely know his name. The second part was that it was much clearer now what was the expectation. The surgeon has to say how much time he expects this to take. We say what are the complications we had during induction. So the surgeon knows, while he was not in the room yet, did we had a difficult intubation? Was it difficult to get IV access? And these are things that were never talked about before. And it came to a surprise to the surgeon that the child needed to stay intubated, and it came to our surprise, for example, that the surgeon thought this child needs to go to the PICU. The culture has changed. The culture of communication has changed. So if I have a concern or a nurse has a concern, it's more frequently, it's not perfect yet, but it's more frequently addressed in front of everybody.
That was a brief look at one of our quality initiative improvement projects at the University of Texas, Houston. I'm Dr. Naveen Vanga, and thanks for watching.